presentations are generally focused around research that examines what patients need and what chaplains do. Our first presenter will be Chaplain Kim Palmer, who's the manager for research projects in spiritual health at Woodruff Health Sciences Center at Emory University. Did you hear that? The research manager. And Kim is also one of our Templeton Chaplaincy Research Fellows, and we're really excited for her and for our colleagues at Emory in terms of the very important ways in which research is being integrated in that department, and Kim will tell you that story. Our second presenter is Sara Hester. Sara is a chaplain at the University of Alabama in Birmingham, and Sara is going to be talking with us about her use of the spiritual distress assessment tool, which is really a very, very exciting project. Part of what you're seeing today are presentations by people who have been with the Transforming Chaplaincy Project as Transforming Chaplaincy Fellows. And as we have been moving along with this work, we have been discovering there's a bunch of other chaplains who are doing some very interesting and important research, and so we're kind of drawing them into our community. So Jeannie Werpsa would be an example, Aoife would be an example, Sara. We're really glad to begin to bring Sara into the community here and looking forward to her telling us about her research. The third presentation this morning will be from the Reverend Marilyn Barnes. Marilyn is a senior staff chaplain at Advocate Lutheran General here in Chicago, and Marilyn is also one of our Transforming Chaplaincy Fellows. The respondent for this block of presentations is Dr. Karen Steinhauser. Karen is one of the leading palliative care researchers in the United States and has been a good friend and colleague for chaplains and chaplains doing research for many years. Karen is a professor in population health sciences and medicine at Duke University. She's a member of the Duke Cancer Institute. She's also a health scientist with the Center for Health Services Research and Primary Care at the VA Medical Center in Durham. And Karen is, among other things, Associate Director of the Program on the Medical Encounter and Palliative Care at Duke and at the VA. So Kim, why don't you come and kick it off?
Thank you. So I'm going to be talking about a particular study that was a foundational study for a broader kind of research program at Emory. The Emory Spiritual Health Department has partnered with the Emory Center for Contemplative Science and Compassion-Based Ethics in an interest in bringing compassion-based spiritual health into the hospital or medical setting. And what we're doing is kind of looking broadly at a secularized Buddhist mind training practice of cognitively based compassion training, or CBCT, and the impact that it might have on chaplains when incorporated into the CPE training for residents, and also the impact it might have on patients. So what we were looking to do was to develop some interventions that were based or adapted from CBCT to deliver at the bedside. And as a precursor to doing that, what we wanted to do was find out, well, what are the things that are really troubling or disturbing people who are in the hospital, so that we know what to target with these interventions. And I'll get to a little bit more of all of that. So our broad long-term objective is to develop and test the efficacy of spiritual care interventions to be delivered by the chaplain at the bedside to reduce distress in the patients and anxiety, and to improve patient outcomes. And specifically for this study, the aim was a couple of questions. What is the prevalence and distribution of sources of hospital distress, and how do they group and travel together? And then sort of beyond that, which I won't be talking as much about today just because of the time limits, is how is distress, along with demographic factors, illness factors, and religious variables, how are those associated with anxiety, and also how are those associated with pain? So this initial study was cross-sectional design. We collected data over a period of 6 months in late 2017 into early 2018, collected data from 2 acute care hospitals within the Emory healthcare system in Metro Atlanta. And what we did to recruit patients is we had a series of people who were helping to do that data collection, and we would sort of assign a unit to the person to work on for the day, and then within that unit, the person would randomize the rooms, so that, you know, we didn't always start at number 1, which is right next to the nurse's station and maybe has the most acuity, and work our way up. Instead, we approached the patients on the floor randomly, and then however many we would get to, and the next day we would target another unit. We ended up going to about 1,600 rooms. In many cases, the patient was asleep or out of the room for a procedure, or actively engaged in conversation with medical staff. We would go back a couple of times to try to catch that patient again, and then if we couldn't catch them, we would just move on. We did end up with with an N of 271. There were also family members that were included in the study, about another 75 people, and those are not included in the results I'm going to present today. So our inclusion criteria for this study is that people had to be adult, speak English or be able to understand English, and be in an inpatient unit. So that meant that we did not include people in the pre-op holding area, we did not include people in the emergency department, just actually in the inpatient units. We excluded people if they had cognitive impairment, either based on our judgment speaking with the patient, or if there was any question speaking with the nurses. We excluded people who were on a ventilator because that would be such an additional burden for them in trying to communicate. And then also if there were enteric or airborne precautions that required the use of the N95 mask, because our research coordinators were not trained on that, so we excluded those areas. We collected data in a tablet-administered survey. Patients reported their were shame and fear. Shame including feelings of guilt or shame, feeling like I need forgiveness, low self-worth, or feelings of being judged. And then the fear factor included fear of the unknown about illness and diagnosis, fear of upcoming procedures, fear of death, and feelings of being frustrated were also included in that. And one thing I will point out is that when we did the factor analysis, any individual items that were endorsed less than 10% were not included in that, because there was not enough variability in order to do the data decomposition. So what we did next was we took a look at some of those poorly endorsed items, and I mentioned those on that one graph, including concerns about the afterlife, questioning my faith, feeling abandoned by God, or feeling angry at God. And because those were important to us, doing the research relevant to chaplaincy, we sort of combined those into a pseudo factor, even though they weren't included in the factor analysis. But these are all very, have low endorsement, less than 10%. So here's kind of a picture of what I've been talking about in terms of how these items hang together. We've got the fear factor that, in terms of being frustrated and fear of the unknown, those were fairly strongly endorsed or frequently endorsed. The shame factor, much less frequently endorsed, and then the faith crisis pseudo factor, at the far right of the graph with the least endorsement, but still all of these things relevant. And what's within that yellow block is the top 10 endorsed items. Whoops. So what we end up with then is taking a look at not only the shame and the fear factor, the faith crisis pseudo factor, but then any of those remaining items that were in the top 10, so that we can take a look at our data by considering what's most prevalent among the patient population. And part of what we took a look at was, if we targeted those things, the shame and the fear and whatnot, and kind of included interventions for these distress points, how many patients would we capture in being able to provide targeted interventions? So targeting shame will get to a little over 70% of the patients, I'm sorry, a little over 30% of the patients. When we add on fear, targeting that factor, we get up to 70%. Faith crisis does not add much because it was so infrequently endorsed. But when we look at the remaining 10 single items in the top 10, we get up very quickly to about 95%. So we've really captured most of the patient population by targeting these things. So we wanted to know kind of who was it that was experiencing this distress. We looked at the association in a bivariate analysis between the distress factors and the single distress items and patient characteristics, that is the items that make up the remaining of the top 10. And what we found that was significantly associated with each distress item is listed here. So significantly associated with the shame factor is having lower educational attainment, being admitted to the emergency department. Significant for fear was younger age and being on Medicaid. With the faith crisis, those were surgical patients, being unmarried, and if you requested a chaplain, that was also significantly correlated. Significant with pain, again, younger age, requesting a chaplain. Inability to sleep, you see younger age showing up again. Same thing with being overwhelmed, younger age, being female. And with sadness, younger age. So you can see that something's going on with age and with younger folks. And length of stay. Significant worry about quality of life was associated with lower self-rated religiosity on that 0 to 10 scale. So we also were conducting additional analyses to take a look at, in a multivariate sense, what are the predictors of pain, both in terms of the 41 distress factors or the 41 distress items or the factors, and also what were significant predictors of both anxiety and pain. So our future work in this sort of broader program of research that I've talked about, we're engaged in a study currently where the chaplain residents have been randomized either to receive the cognitively based compassion training early in the residency or later in the residency. And we're taking assessments at 4 times during the year for those residents to find out what are their measures of well-being in terms of anxiety and depression, what are their levels of burnout and compassion fatigue, and we're also using a video task to measure empathic accuracy. What we're hoping to do is to find out, before and after each group takes the training, do those measures improve? And then also, is it better to have the training in the CPE program at the beginning of the residency year or further down the residency year once they've gotten their feet wet and gotten some experience? We're also looking at patient outcomes. So when those randomized chaplains are off seeing their patients, we'll take a look at patient outcomes for the different groups, those that were received spiritual care from a chaplain that was trained in CBCT and in CBCT adapted interventions, and those that weren't. And we'll look at outcomes of well-being, pain, how much opioid medication they're receiving. We also are sending or intending to send patients home with an electronically activated recorder so that we can do linguistic analysis based on what it randomly records during the day to find out whether people who were treated with the CBCT-based interventions have greater social contact, use more emotion words in their language, spend more time around people, spend more time laughing. And then there are also some qualitative studies underway to look at how CBCT is actually being adopted and used by the chaplains. And that includes interviews of the chaplains themselves. Also, we're planning to record some of the chaplain and patient interactions to see how it is that we can tell within those linguistic analyses how the chaplains are incorporating CBCT into their interactions. And then also we'll be taking a look at chaplain chart notes to see whether the CBCT trained chaplains are different in terms of how they chart, what kinds of things they bring up in their note than those who have not yet received that training.
Assessments. That's something that we do every day, but that word is kind of scary to a whole bunch of us. But it is something that we do all the time. We're making multiple assessments every day. Do I have time to go see this patient? what do I need to do? What are they facing? So we're making assessments all the time, but a lot of times we're worried about the formality of that. And there are different tools that are out there to be used, but it's really something that we do all the time. Sometimes we need to address it from an even bigger perspective. Are we doing the right things? Are we seeing the people who we need to be seeing? Do we have adequate staff to? So these are the kind of questions that management is asking, but those are also important questions for the profession as a whole and for us as individual chaplains. So I work at the University of Alabama at Birmingham, and so to just give you a picture of the landscape where I work, in 2016, because that's when I did my research, so it's an 1,157 bed hospital, so it's a pretty big place. There are 264 ICU beds within that 1,157 bed hospital. There's a 25 bed ACE unit, which is acute care for the elderly, and then it's also a level 1 trauma center. So that is covered 24/7 by 10 staff chaplains, 6 resident chaplains, and 4 PRN chaplains. So a lot of need, a lot of people. So problems that occur. There are patients and caregivers who have needs that we aren't identifying, that we aren't meeting their needs. So, and we are too big of a hospital and too few people for us as chaplains to screen each patient for the need. So we currently receive consults through our medical record system based on these 2 questions. Would you or your family like spiritual support from our team while you are here? And then the second question, do you have any religious or cultural needs that will help us better care for you as a patient while you're here? So I personally have done some assessment of how well I think that works. And so I have some problems with these trigger questions. So the first one is that the questions are subject to nursing bias for or against pastoral care. The questions are part of the nursing admission assessment, and they are not mandatory questions, so they don't have to be asked. So if the nurse doesn't think pastoral care makes a difference, she doesn't have to ask the question. And she can also say, would you like to receive spiritual support from our team while you're here? You won't spiritual support while you're here. So it's subject to that bias that she may or may not have. The second question, the second thing is that they're subject to patient and or caregiver bias towards the word spiritual. Now, in our effort to be inclusive to a vast range of people, we've adopted to use the word spiritual. However, in Alabama, if it is not covered and purified by the blood of Jesus Christ, that is that new age stuff, and we don't want it. So, that question may turn some people off that otherwise would be interested in receiving spiritual care. So, secondly, the first question, even when we do get a positive response, it measures receptivity rather than need. Yeah, it'd be fine if they come by. It won't bother me if someone comes by. It's not the yes, I have this desperate need to see somebody. We're not identifying those people necessarily. And then the fourth one is that the religious needs that are identified are usually dietary or blood product needs. The patient's Muslim, Jewish, Seventh-day Adventist, they don't want pork, or they might want vegetarian if they're Hindu, or they're Jehovah's Witness and they don't want blood products. Those are great things that we do need to know about to meet their needs while they're here, but it doesn't require a chaplain to go visit them to take care of any of those needs. So our questions aren't necessarily identifying who we most need to be seeing. So my hypothesis or my concerns, well, I wonder, could functional status indicate a need for pastoral care? Because I'm interested in the practical application of what I do. So my hypothesis is that patients who have a decrease in functional status will have higher levels of emotional or spiritual distress, and that patients who have a low baseline or a change would also correlate to caregiver stress. So the study assessed patients and caregivers on 3 different units: our acute trauma care unit, our ACE unit, acute care for the elderly, and one of our hospitalist units. And so we looked at each one of those units over a separate 2-week period. We invited all patients and caregivers to participate with the exclusions that are there. So basically, if you're too young to consent, if you are in custody, anything that you would have a lack of capacity to give consent. So how I did it, so I printed out the unit, census unit for each unit, and we offered to everybody there, would you like to take part? And then we also had surveys that we gave out to the patients and the caregivers for them to fill out. So the caregivers filled out, additionally, a caregiver assessment questionnaire, or the caregiver stress questionnaire, caregiver stress assessment questionnaire, anyway. And then the chaplain interviewed the patient regarding using the spiritual distress assessment tool. We also completed a chart audit on that. We looked at pain scores, we looked at number of diagnoses they had, we looked at distance they lived away from the hospital, we got all kinds of good additional information there. So the documents were then sealed in an envelope and sent away for data entry and analysis. So why did I use the particular tools that I used? So the CATS and Lawson, or Lawton, I think I spelled it wrong here, I get confused whether it's the Lawson or Lawton, but the CATS is an assessment tool that nursing does regularly that looks at the ADLs. So is the patient able to bathe, eat, feed, walk, toilet themselves? The other one looks at the instrumental activities of daily living. So am I able to balance my checkbook? Am I able to drive? Am I able to get where I need to go? Those kinds of things. And an advantage of the CATS that I saw over our current questions that are done on the nursing admission assessment, needs may change. So this CATS is repeated every third day. They might not want to see a chaplain the day they got admitted, but if they're here for 2 weeks, something's changed, that might change. So this would be an opportunity to have it be re-triggered if this were able to match. So the spiritual distress assessment tool, why did I do that? It makes use of a chaplain's expertise was one of the things that appealed to me. It was a free tool, so I looked at some other things that were out there. This was a Sara funded research project, so that meant it needed to be as inexpensive as possible. And we're able to assign a quantitative value to the assessment. But another thing that fit in with this tool and my hypothesis about the decrease in functional status is that 2 of the domains that it looked at, I thought might correlate to that. So that too is another reason why I thought this one might be able to give some insight to would this be a good trigger. And then the caregiver stress assessment, again, that was a free tool, it was quantifiable, and it had been used in research. So looking at the spiritual distress assessment tool, this was developed by researchers in Switzerland. It had been validated in a study there. It utilizes a structured and scored interview by the chaplain. And so it looks at these 5 different spiritual needs. And then so for each one of them, you can score it on 0 to 3 based on unmet, little bit of difficult, or no unmet need, mildly, moderately, or severely unmet need. So when we offer this, who responded? So we had both patients and caregivers. So we would offer the patient the opportunity, we would offer the caregiver the opportunity. Sometimes we had both together, sometimes we had one or the other that responded. And these units and the dates that we did it were June through August of 2016. And so we had the response again of the patient caregivers and the dyads of the 2. So this is just a look at the spiritual distress assessment tool to show you the questions and the scoring, how it's done. So this is in a 30-minute interview. You're talking with the patient, you're going through these things, and you're hearing their story. And you don't necessarily ask each one of these questions because the story may reveal the answer. But if the story doesn't reveal the answer, then you do ask the question to get to that area of need. And then this is the second page again. So looking at who participated. So we had 80 patients that were participants. And that's either the 80 unique patients that were part of it. So either the patient themselves or a caregiver affiliated with a patient participated, 80 different ones. So the age, 52 plus or minus 20. So we ranged 18 to 93, 52% female, 65% white, about half between medicine versus surgery. So all the trauma patients were surgical patients. And then just a little bit more of the distribution there. Average 4.4 on the day that the assessment was done was 4.4 plus or minus 5 days. And we looked at some of the other things there are the things that were looked at from the chart audit the whether or not they had a fall, cognitive status and screens. And so we use those cognitive statuses to determine whether or not the patient would be able to participate in the use of spiritual distress assessment tool. And so again, here are the caregivers that took part and some information about them, which matches up pretty much along with what the information was for the patients. But we have a listing out of the relationship of the patients or the caregiver to the patient, and then whether or not they lived with them or lived away from them. So the majority of these caregivers didn't live in the home with the patient. So some of the unique information about the environment and location where this happened. The spiritual distress assessment tool was developed in Switzerland, and I don't know the exact religiosity of Switzerland, but we know that Europe, Western Europe, is much less religious than the U.S., and specifically much less than Alabama. So do you belong to a spiritual or religious group? 82% of patients and 88% of caregivers belong to a religious group. And when was your last contact? Almost 75% within the past month. So that's perhaps unique to Alabama even from the rest of the country. But so I said everybody has a faith. We've all got our private faith, whatever it may be. But in Alabama, your faith is also very public. It's a part of your everyday life that you talk about. Religion is not a taboo topic in Alabama. So it's out there every day. So knowing something about your situation, but I think it's really interesting that this tool that worked in Switzerland is also effective here in Alabama with that very vastly different makeup. So here's the distribution of the scores, which if you look at it, it's kind of a bell curve with a really wide standard deviation. If you, although I don't have bell curve there or the standard deviation for you, but you can see the bell curve shape there even among that distribution of their scores. So looking at the different domains, so the two domains that are highest, the yellow is the severe. So is life balance and maintaining identity. And both of those, in my opinion, correlate really a lot to the fact that my functional status has declined. I'm not able to do what I was able to do anymore, so my world is turned upside down. And if I'm low on that instrumental activities of daily living, maintaining my identity as the provider for my home or the caregiver for those, again, that's severely diminished by that. So there's additional things are there, but for the most part, the other areas were not near as high. Those two really did fall out high with this group of patients. Be interesting to see if that's true among other groups of patients as well. Since half of my patients were trauma patients, that may have skewed some of the results of here to not being able to be as generally applicable, but I tried to get a section of people, so I wanted to have generally applicable information if possible. So, and just to look at, so how many needs did you have? So we only had one patient who had no needs on any of them. And then we had as many as 45 though that had a little bit of unmet need on all 5 domains. So it had a pretty big effect in some way to be a patient. So looking at our scores, I divided this up. The blue, which is the non-demental, was a 0 to 5 score. The red was a 6 to 10, and the green is 11 to 15, which is the score range. And so we looked at, does that correlate to the CAT score, which is the functional status on the activities of daily living? And you can see, again, the higher the stress, the lower the CAT score. So that does correlate, which is the correlation, which is what I was wanting to find. And then we look at compared to caregiver, and we see that there's even a statistically significant difference with the caregivers. And look at just, for the red being the severely distressed, higher caregiver stress, the change from baseline to current. I think that drop is a really significant something to look at. We also looked at patient health literacy, and we see on the far right side of both of them, we look at the trouble understanding medical terms. We have a whole lot of difficulty with our patients and caregivers being able to understand what is all this jargon that's being put at them. So that's an area where we as chaplains can perhaps intervene and make a difference. So incidental finding, there were a large number of patients in our ACE unit that were excluded because of their cognitive status and not having a family member present. In our hospitalist unit, there were patients that were excluded because they were on radiation isolation and chaplain wasn't able to go see them. And then there were a number that were excluded because of their inability to read or write. And the older our interviewer was, the more willing they were to share that as one of their handicaps. So literacy and vision capabilities need to be looked at. 74% of patients surveyed have moderate to severe spiritual distress, which would warrant a visit and assessment by a chaplain. And that does correlate to the CAT score. And I already said the last. So further analysis of data to determine a critical value of the CAT score is something I'd like to do, and then be able to implement that in a trial study. And then further look into the need for caregiver support for patients with dementia, and further study on the needs of patients who are in isolation. And then really why this matters to me. This is my inspiration. So if you'll see on the top left, the woman sitting, the older looking woman sitting is my now 100-year-old grandmother. This was at her 99th birthday party. Standing behind her are her two 90-something-year-old sisters. All three of them have macular degeneration. So the other four people with them are my dad and his three sisters who are caregivers. And they are very stressed as my grandmother is no longer able to see, and my aunt who lives across the road is doing much of the work of caregiving. One of the great aunts has moved. At this time, all three of them were living independently in their own homes. One of them has moved to an assisted care since that time. On the picture at the right, the woman with the young boy is my mother, who had complications of, had diabetes, hypertension, arthritis, asthma, was on dialysis for the last 4.5 years of her life. So we did a whole lot of caregiving for her. The bottom right is me and my husband. My husband died 1 year ago yesterday from an unexpected heart attack. He also suffered from an anxiety disorder, so I learned a lot about caregiving there. And then the young couple is my nephew, who is 21, and his 21-year-old wife, who was diagnosed with stage 4 cancer last January. So all of us have struggled with where is God in this? Our faith has helped us through it. But it's an everyday burden that we face, and I know our patients are facing, and I want us to be able to make the biggest impact by making sure we are seeing the ones who need us, not merely the ones who would like it, who would be okay if somebody prayed for them. Thank you.
Greetings, everyone. I have a question. How many of us in this room, by a show of hands, identify as a chaplain? Thank you, hands down. How many in the room identify as supporters of chaplains? Thank you very much. So now I encourage you to come along on a journey with me, a chaplaincy research development journey. There will be no p-values, no odds ratios, no betas, no relative risk in this presentation.
I think you're done.
I am grateful, however, to have the opportunity to share with you about the Advocate Chaplaincy Taxonomy journey. Some may call it the Massey Taxonomy, some may call it the Barnes Taxonomy, some may call it the Massey-Barnes Taxonomy. However, it is the Advocate Chaplaincy Taxonomy, a normative language for chaplains. The taxonomy was developed using a total of 7 methods, both qualitative and quantitative. We started with the literature review, which consisted of 4 published inventories of chaplain activities. We then went to a retrospective chart review, where we had 1,126 patient encounters, where the patient saw the chaplain at least one time in the intensive care unit. There were 5 focus groups with 27 participants in different locations and 8 informant interviews. 3 chaplains, one who is here, Annalie Heisey-Pearson, from 3 different hospitals participated in a self-observation phase where each chaplain self-selected activities to be recorded in an electronic collection tool. For each activity, they were asked to select an intervention that they performed, the intended effect and method corresponding to the intervention, and I will define those a little bit later. And we asked them with whom the intervention was performed. We didn't stop there on this taxonomy research journey. We went to experience sampling, and during this phase, the chaplains were paged 6 times, in addition to however other many times their pager went off during the day. And during this time, they were asked to identify on their electronic device, which happened to be an iPad mini, if they were engaged in a spiritual care encounter or another activity, such as administration or a personal item. We do eat and other things as chaplains. If a spiritual care intervention was selected, they recorded again the intended effect and the method and intervention using the normative taxonomy or normative language we had at that time. Next, we went to concept mapping. And this particular research method was not in our original proposal. However, as we were going through the actual research process, we thought that including this would give us more diversity in having and more validity, if you will, with the research that we were doing. And so in the middle of a research project, we changed one of our methods, not recommended. So we went outside the walls of Advocate at this time, and we actually engaged 30 chaplains from across the US with different faith traditions. And the participants were asked to group the inventory items into 3 categories. Again, intended effects, methods, and interventions. Then we went to inter-rater reliability. And that consisted of 27 chaplains who were asked to identify taxonomy items from spiritual care encounter vignettes. We also had each one of the research chaplains to document in case study format 2 encounters. And we had them find a particular person that they had had an encounter with. It could have been staff or a family member or a patient, and actually use the taxonomy to document that in a case study. I know I spent a lot of time on that slide. You all were looking for me to click, I know. Okay, so you might ask, why did we go through this journey? Why do this? As this slide reflects, one person uses one word, the other person does not believe that it means the same thing. As chaplains, we use different terms to explain our plan of care and the care that we provided. The lack of a normative language contributed to a communication breakdown, discrepancies, if you will, among chaplains as well as the interdisciplinary team. So, when we move to a uniformly naming things, there is better communication between chaplains. There is better communication with the interdisciplinary team. There is improvement in requesting and referring chaplaincy services, and an enhanced ability to study and research chaplaincy outcomes. So as you look at this slide and you get a little chuckle, I'll share a little story. As I was growing up, I learned that they were trousers. And so that is what I say. Go get your trousers. Did you iron your trousers? Put on your trousers. My husband grew up saying pants. My children got confused when I said trousers. It means the same thing, but we were saying things differently, a breakdown in communication. As chaplains, we may say, I spent time with that family because they lost someone. Or we say, I did active listening with a particular family that was grieving. Ultimately, we journeyed with someone in the grief process. How we approached it may be different, but what we did was journey with someone in the grief process, which is a taxonomy item. Okay, so the initial advocate taxonomy research journey, because we're still on it, included 67 chaplain participants. We reviewed 538 possible interventions during this time in the lit review section, the retrospective chart review, and the focus groups. We assessed 890 chaplain activities during the self-observation and experience sampling steps. We rated the frequency and importance of 107 items during the concept mapping step, and had an inter-rater reliability of 0.093. Let me say that again. We had an inter-rater reliability of 0.093. For social psycho, 0 point, thank you, 0.093. For psychosocial disciplines, 0.08 is acceptable. So the inter-rater reliability, or the use of this tool, the reliability of the taxonomy, is significant. So the taxonomy is again comprised of 100 items and include intended effects, which reflect the desired purposes, goals, and outcomes of a chaplain's care or ministry. The methods, that is the manner by which a specific gesture, action, or activity supports the intended effects. And the interventions, which is any ministry / care or gesture, actions, or activities by a chaplain. And when we take that intended effect, method, and intervention, we can build a pathway. So a pathway helps us to say what we did, excuse me, either to describe or to prescribe. And you can see here that you can have one intended effect, one method, and one intervention, or you can have one to many to one, one to many to many, many to many to many. And as chaplains, we have numerous pathways when we go into a spiritual care encounter. And I actually, when we were developing the taxonomy, I had an encounter, and I actually had 21 pathways. So I'd like to share a video, if I knew how to get it going. This is not the touch screen.
Is the mouse, can you put it up?
Oh, found it. About how we use the chaplaincy taxonomy. And you might be familiar with the actors that you see. At least I hope you will be. So while that's coming up, which I hope it is, Andrew.
The chaplain is making initial visits on the rehab unit. He enters the room to meet a new patient who is a female African-American Baptist. The chaplain is a male Unitarian Universalist.
Good morning, Mrs. Davis. I wanted to introduce myself. I'm Chaplain Steve George. I'm the chaplain who works in this rehab unit where you are. I wanted to introduce myself to learn how we could best support your religious and spiritual needs while you're here. Do you mind if I sit down with you for a moment?
Please, have a seat. Thank you for coming. Well, I want to tell you that my Lord is the solid rock on which I stand. I'll be up and going strong again. This hip surgery was a blessing, and I will work hard here to make it prosper, and my faith will help me get through it.
That's wonderful to hear, and I certainly want to support you in that. Sounds like your faith is a great support to you, and it says in your information sheets that you're a member of Plymouth Baptist in the city. Does your church know you're here?
You know, I don't know if they do or not. Could you call them and let them know?
Absolutely. I'll call them right as soon as we're done talking. Is there anything else that we could provide that would help you in terms of your faith?
Well, there is something else, and I hope you don't think it's unusual. You see, my sister, she went Catholic a lot of years ago. Raised Baptist, but she went Catholic. We can disagree about that, but there's one thing. You see, she gave me some rosary beads a long time ago, and I kind of feel good when I hold them when I pray. Could you get me some of those rosary beads while I'm here?
You know, I actually carry some with me because they are frequently requested. Here's some rosary beads we provide free here at the hospital. I'm glad I had them with me to give to you today.
Well, when I get ready to go home, I'll get these back to you.
Please, they're a gift. You can keep them, and please remember us here at the hospital in your prayers when you hold them.
Well, that's very sweet. Now, will you pray for me, Chaplain? I'm so blessed that you came here to meet me today.
The chaplain prays a prayer with Mrs. Davis, praying for her healing and for the rehab unit and for her congregation. The chaplain promises to visit Mrs. Davis regularly during her stay on the rehab unit.
As you can see, the chaplaincy taxonomy is used to build what actually occurs when we have spiritual care encounters. And so the chaplaincy taxonomy is currently being used in the electronic medical record at Mount Sinai in New York, as well as Advocate Healthcare. It's a widespread use in the United States, Canada, and Great Britain for chaplaincy training and education, as well from a descriptive perspective and a prescriptive perspective. It is being translated into Dutch, and the United States Navy is piloting it in their online Navy chaplaincy documentation. So where do we go from here? We didn't develop the normative language just to kind of leave it here because it's an evolving thing, and it was actually focused in a palliative care ICU setting. So when I look to the future, I think of this journey to continue with having the resources and the time to accomplish the following, which are focused on supporting the evidence-based practice of chaplaincy vocation, and enhancing the care and communication of our care. Thank you. Since we have the data available in the electronic medical records, a retrospective chart review to assess item frequency and the beneficial and how beneficial it is would be great for laying the foundation for the addition and deletion of items through the establishment of a reliability tested process and monitoring it for effectiveness through a review committee. We would be able to look at pediatrics, hospice, prison ministry, and others as it applies to the chaplaincy taxonomy. The establishment of a chaplaincy taxonomy users group, starting with the communication of a survey of the over 300 persons who have accessed the chaplaincy taxonomy. Finally, incorporating the chaplaincy taxonomy into the base of EPIC, the electronic medical record system, would provide consistent availability and access for various healthcare systems, not only hospitals, but medical offices and outpatient sites. This would also help us to say, this is what chaplains do. This is the value of chaplaincy. This is what we do. If you would like more information, you can access the Chaplaincy Taxonomy research article as well as be one of those persons in the CTUG, Chaplaincy, the Chaplaincy Taxonomy Users Group. Thank you.
Well, first of all, thank you so much. Please holler if you can't hear me in the back. But it's really exciting to be here. I met George several years ago when we were part of a series of studies that were sponsored by the Healthcare Chaplaincy Network. And there were 6 studies at the time, and really some of the first that were sponsored in this arena. So to see this many people in a group and chaplain fellows, research fellows, is really exciting. What I wanted to do was first talk about a couple of overarching areas, and then that I think are link each of the studies that we've been shown today, and then ask some particular, or give some reflections and ask your thoughts about some next steps as well, if that's okay. So, in some ways, this gets, I'll give you my 3 kind of soapbox issues that I think really got echoed beautifully in a lot of these studies. And I would say the first one is really what this effort in chaplain research is all about. I come from the world of palliative care, and a number of years ago, Jennifer Temmel published a landmark study in the New England Journal of Medicine in 2011 showing that palliative care in advanced lung cancer patients, when paired with other care, when it was co-occurring, showed that patients lived longer and had better quality of life. And yet they were palliative care consults, and there was very little detail about what did the team actually do. And so while there were tremendous findings, again published in the New England Journal, the conversation in palliative care became, what's in the syringe? What is it in palliative care that makes a difference? And I think the chaplaincy is in the same place. It's not the syringe, it's in a sort of Christian-centric language, it's in the chalice, or a Judeo-Christian-centric language, but what is in the sacred object? What is that, what occurs in that encounter? And really looking at sort of what are the nature and scope of concerns, which you have really beautifully documented in the distress examination. What do we consider appropriate ways to address those concerns? What do we know about the course of treatment? And then how would we measure the impact of these various interventions? And I'm speaking to the choir, obviously, but you know that's the crux of where chaplaincy is right now, and really being able to give fine-grained and rigorous approaches to answering those questions. So that was exciting that there's been a lot of movement here, and I want to ask in a moment a few clarifying questions about some of those issues. The second is that we do so much work in patient care, and yet we know, of course, and it's part of the chaplaincy mandate to address caregiver spiritual needs, and so such opportunity to expand our interventions to addressing caregivers as well, and that was addressed certainly in several of the studies here. And then finally, my last soapbox issue, which I'll get to in the end, is there are great interventions, there's great work being done. We can work to identify the nature of those, the scope, the impact, and yet if we can't translate them to the rest of the healthcare team, we're not in good shape. So I want us to think about, with all of these interventions, what is the impact on translating the incredible information that chaplains glean at the bedside with the rest of the healthcare team to impact overall care. So those are 3 things I would love for us to think about, and hopefully you'll think about with me as I offer a few reflections, and hopefully you will have others as well, maybe in those veins or maybe in something else. So perhaps what I will do is go along to the first presentation around prevalence distribution and grouping of sources of distress. So first of all, thank you for a really terrific and well thought out presentation that you and your team have done. Just a few questions I wondered a little bit more about to get your thoughts. I was really curious about the factor analysis where you on the one hand, had many of the 10 items that were hugely important, and yet sort of didn't come together in a factor or in a couple of factors. Rather, you got fear and shame. And I would just love to hear a little bit more about what you think is going on there.
Hello? So that's a great question, and one of the things that was one of the surprising findings that we came to was this idea that of all these separate items that people were able to endorse, they really are distinct items. We had thought that there might be several main categories of distress, but it really looks like many of these individual items stand alone as specific points where a chaplain can intervene.
Mm-hmm. And many of them seem to be related to a physical experience, and as distinct from some of the items that we think about sort of being in the chaplain wheelhouse with shame and fear and spiritual struggle. Any thoughts about that?
Yeah, so some of these things were very situational. So, not having enough support while you're in the hospital, or being away from your faith community, or missing your pets was one that actually a lot of people felt. So, I think that the way that the chaplain can help with some of these physical or more practical or situational items are to be able to listen to them, to recognize them and acknowledge them, and then to maybe help patients consider what kind of resources do they have in their life that they might be able to address some of these things. Certainly if we're talking about something as fundamental as pain, we can look at what's going into making up that degree of pain. And a lot of times it's not just the physical aspect of pain, but it's the emotional or spiritual distress that's contributing to that.
Mm-hmm. I know I'm way out of my depth here with this audience, but I was thinking about so often we make that dichotomy of the physical and the spiritual, and if we're embodied beings, then, and spirituality is an embodied practice, then certainly it would be, I would imagine, within the chaplaincy practice to address those.
I can give one quick example that jumps to mind, and that's I saw a patient one time who her biggest distress was that she hadn't been able to brush her teeth in several days. And so I got her the basin, and I got her a cup of water and her toothbrush and toothpaste, and she was able to brush her teeth. And she said that she felt like a whole new person. So that's something that, not always in the chaplain's wheelhouse that jumps to mind, but that was her point of real distress at that moment.
I have a colleague who is a palliative care physician who was had inherited a patient who had been fired by a number of physicians for his non-compliance and with opioid prescriptions. And so my colleague decided to take him on and thought, at first, I'm just not going to change his pain medication. We'll keep it where it is, and I'm just going to see him over a period of time. And so they were talking, and just in the office, and he said, so tell me where you live. And the guy said, well, I live alone, and the man was on disability, and so my colleague said, so what do you do all day? And the guy said, well, I think. I sit around and I think. And he said, well, what do you think about? And the young man was a veteran, and he said, well, I think I did a lot of things that weren't very good. I killed some people. I think about that, and I think about whether I'm going to hell or not. And over time, as this came out, the man's need for opioids decreased. So again, an opportunity for the intersection, which again, you all know so well. The other thing that I wondered about, that the issue about the pain factors and then the shame and the fear, has to do with how we conceptualize stress and distress. And in the social science literature, we think of those as two different things. We think of stressors, and then we think of reactivity to stress. And so I'm wondering if in some of those sources of stress we have stressors and then reactivity, shame and fear. And it makes me think about your stories about pain. What is the experience of pain, and then what is the story that goes along with it? Or if I'm having dyspnea, if I'm having shortness of breath, and I've been a smoker what's the story that goes with it? Is there self-blame? And I just think about, I wanted to hear your thoughts on that concept of stressors and then distress as distinct, and what you think might be in play, or if that's maybe in the mix.
Yeah, I think that's a really good observation, and the thing that's, I think, where those two come together in the work of spiritual care is in addressing, sort of the, it can be either the source or it can be the reaction to the source. And being able to meet a patient at that point of stress and talk about, if they're experiencing shame, being able to explore what that comes from, and if they're experiencing a particular stressor, being able to explore what's their reaction to that that's impacting their life, and how might we be able to support them in easing some of that suffering.
It made me think about, on the way to dinner last night, you were talking about the framework of Buddhism and the second arrow. And if pain is the first arrow, is the story of shame or the story of blame the second arrow? And you might say,
can I tell the story?
Sure.
Because
Yeah.
that jumped to mind as well, but I didn't know whether this was a forum for that. But there's, in the Buddhist kind of world concept, there's this idea of the second arrow that's part of our training for CBCT. And it's the idea that in life, there's many things that happen to us that we can't control. Maybe we get sick or lose our job, or a loved one dies, and that's like life shoots us with an arrow. But it's our reaction to it. For example, if we're feeling shame or regret, or we're spending our time worried about the future, it's like we shoot ourselves with a second arrow. And to the degree that we can help patients see it and recognize it and kind of separate out their reaction to their situation from their situation, we can maybe help them pluck out that second arrow and lay it down to reduce their suffering.
If I were to just really be quick, sort of some other opportunities that I thought sort of existed within this. I know this was largely in an inpatient setting. Is that correct? I mean,
fully inpatient.
Yeah, so I thought, gosh, this would be fascinating to learn about in the outpatient setting, how that varied over time. I also thought about your exclusion criteria, people with cognitive impairment, people who are on a ventilator, people where there was a concern that they couldn't be speaking. And I thought, again, that might be a fascinating place to look at caregiver distress in those settings, where they're often in that situation of being the surrogate decision maker. I know these are probably things you've thought of. The other thing would be to really look at this distress with, I know you looked at a few anxiety scale, but things like the MD Anderson scale, and really be fascinating to look a little bit at how you could do some comparative validation along that line. If I go quickly, because I know I just have a few more minutes, to the second project. Again, really interesting, because here we are wrestling with that there really are not strong gold standards with regard to screening or distress. So one of the things that I thought, sort of in your questions around the triggers, I thought you conceptualized that really beautifully about the challenges and the bias that is part of those trigger questions that we usually do, or often used, or would you like to see a chaplain? That's even sort of more difficult, more problematic. But I thought about that really the research question is a mix of looking at both the need for screening and then the need for assessment. And so both were in the mix there. As a researcher, I still want to learn a little bit more about the validation of the SDAT, because it's had one-time use in Switzerland, and it's really promising. And I want to know more about sort of like inter-rater reliability on when you have a subjective assessment from an observer about needs and unmet needs. And can we look at how those move with patient-reported and caregiver-reported distress and needs? So that would be really fascinating to do. The other thing in terms of connections is, again, you made this point, and I was going to ask more about it. If you're looking at the CATS as a functional assessment score, in some ways it's not surprising then that you, as you pointed out, saw correlations between that and issues of identity and issues that would really have to do with a change. And so I'm curious what you think about if you were to, just from your experience as a chaplain, think of other units in the hospital. What are some areas where isolation or control do you think might really rise up? And I'll let you answer that, and then I'll ask the follow-up about measures.
Well, isolation, I would think our bone marrow transplant unit, where and any patient that actually has isolation precautions, because I personally like, ooh, I got to wear a gown, I got to wear gloves, got to wear a mask. I don't. And how much that for chaplains or any staff does that patient get as many people going into the room, seeing them, spending time with them, or family not able to be in the room with them. And one of the things that I want to be able to find the clinical triggers for those different things. And the CATS was attractive to me related to that, because if we see a patient can't walk, we make a referral to physical therapy, and the physical therapist can come in and the patient can turn them away. But we've identified a need that we think they're going to have, and this is the person who we identify can help with that need. And I think pastoral care should be the same way. And you had a two-part question. I think I only hit one part.
It's already connected, so then it made me think about, so it would be a good thought exercise in the future to be thinking about, so what are the triggers for the other kinds of dimensions within that assessment tool, for example, so or in other settings that really might uncover need.
And the thing that I think about using the SDAT in Switzerland versus Alabama, though, is that those questions get not at the religiosity and the religious needs being met, but more at the underlying spiritual, the not based on your religious needs, that would go across the board to any situation. So I think I think the fact that it was still identified need in this setting, I think that does provide some additional validation to the tool.
I know I'm running out of time here, but I have a quick question just because of the sensitivity of doing an assessment, a standardized assessment, and sometimes the pushback on that. So when you were doing that, do you feel that you were doing assessment or ministry?
Both.
That's what I wondered. So it was a conversation out of which you gleaned information that could be reported. Great. I have plenty of other comments, but I want to, in my last minute remaining, move on to Marilyn's contribution, which was really fun to see the taxonomy, and maybe this relates most readily to my third sort of soapbox issue around communication with the team. So I love that you have really developed standard language for chaplains to use to markate what it is that is happening in the encounter, what's in the syringe, right, for chaplaincy. So my question to you is, what steps are you thinking about that relate this back to the rest of the team, that maybe facilitate communication with the team?
Thank you, that's a good question. So when I interface with the, say, ICU team, for me to be consistent with saying this patient is grieving, so I'm present with them in the grief process, and I see the intervention that needs to occur of these things, and then the chaplain that comes behind me says the same thing and uses the same terminology. So instead of saying, as I gave the example, I used active listening, and Kim says, I listened to the patient, or I say that I provided them a religious item, and Kim said I gave them a rosary. If we talk in concrete and the same type of language, similar to the physician when they give a blood pressure medication, we gave this as the intervention, and this is what we believe needs to occur next, and to engage the rest of the medical team in that. Similar to how the medical team engages us, right? So to also engage them, and I think that's also providing them with care when we do that.
Two quick comments, and then I'll finish or ask for other comments and questions. I thought there was sort of really wonderful alignment between all three of you, because there are opportunities to really work together. Because I was thinking about the taxonomy and then being able to map that with distress in different units. So that would be really fun to look at. The last comment I'll make is that the documentation related to a pilot project we're working on at Duke, we actually did some teaching of this in the Healthcare Chaplaincy Network and at the VA, where we are working with our chaplaincy team to use a structured communication format called SBAR, which stands for Situation, Background, Assessment, and Recommendation. And maybe you're familiar with it, but we've been really workshopping cases and trying to identify ways to shorten a description to 1 or 2 sentences for each of those items. And the most challenging for the chaplains have been standard language around assessment and then really around recommendation. Because what we hear most from other clinicians on the team is, I really need a bulleted approach to understand what really happened in here and what should I do about it. How can I feed this into my team? Can I take the good information you have? And so a taxonomy, I think, is a wonderful step toward that kind of standardization and integration of chaplaincy with the rest of the team.
So within the advocate system, we use SBAR. And I see 2 chaplains back there who I know actually use that on a daily basis with documenting and making recommendations. And so that is something that we can also follow up and work with you on.
Thank you. I'm over time. Are there other questions? I think George is going to come forward.
Thank you, Karen. We have about 10 minutes, so if there are comments or questions people want to make, if you would step up to the microphone.
Half-time researcher for Ascension Health, which is a Catholic health system. So I am pleased to announce that we are in the beginnings of our first ever Ascension system-wide spiritual care research project, looking at how chaplains can provide services to CHF patients outside of the acute care setting. And so this is really a comment to say, when I designed the protocol for the research study, I needed to find a way to record what the chaplains did in their encounters with the CHF patients so that we could show, hopefully, that it reduces their religious struggle, increases their level of peace. And so I'm using the taxonomy as a means for having a common language and providing field notes. So I've instructed all the chaplain interventionists I even gave them some examples and wrote up some examples of interdisciplinary notes or field notes to say, if you're using the taxonomy, to record what happened in that encounter. So I'm really excited that you provided us with a language, because so often it is very difficult to say, well, I provided spiritual support or a kind ear. Well, what the heck does that mean? And so I just wanted to thank you, and hopefully I will have really good feedback on how the chaplains are using that.
Thank you so much, awesome.
Thank you, Beth. Just again, a bit of shameless commerce. If you are interested in the taxonomy article and you don't want to download it from the journal, it is one of the articles that was reproduced in the evidence-based chaplaincy care reader. So those will be available at lunch, and the taxonomy article is there. Let me just, Deb, before we recognize you here, let me just say the whole issue of research about best practices in chaplaincy documentation has kind of come up in what we've been talking about here, and we didn't have time or space to actually invite Katie Reimer from Beth Israel Deaconess or Lex Tartaglia from Virginia Commonwealth, but Transforming Chaplaincy did provide some support and sponsorship for a subgroup of chaplains who are working in palliative care to collect a sample of chaplaincy chart notes from palliative care cases and examine the strengths and weaknesses of those. Some of you may have heard Katie do a workshop about that project in the APC meeting in Anaheim, and that manuscript will be submitted for publication shortly. So lots of areas for research about best practices and documentation. How can we use the taxonomy? How can we use other things? And so that one project will probably appear in the Journal of Healthcare Chaplaincy in the next 6 months or so. Deb, why don't you introduce yourself?
Hi, I'm Deb Marin. I'm from Mount Sinai.
Louder.
Hi, I'm Debbie Marin. I'm from Mount Sinai, and George Bichette is a wonderful colleague, and I have other great friends here too. I wanted to comment about, I think back when I heard these presentations, and I'm looking at what I'm doing this afternoon, is I remember back in the early 80s, there was a lot of work to determine what caused GRID, which then became HIV. And within just a few months of one another, different academic institutions figured out what the virus was. And I bring that about because the theme I'm seeing here is that a lot of us are doing the same things at different sites. We have a lot of information on taxonomy. Thank you so much, Advocate, for that. We're doing SBAR. We're using to question the rush protocol and determine if there's any value in EPIC. And I bring this about because it seems like we're at a point where there should probably be, and this is the place to have a kind of mini consortium of people who are doing research in the area to get together and use our data collectively to really move the field forward even faster. So one thing I do have to say, because everything that you guys are saying, except we're not doing as much as what you've been doing actually in Alabama, I have to say that for sure. And Alabama is a different place. Dear friend who lives there, she's Jewish from Detroit. It's very different.
It's very different for her.
So I just wanted to make that one comment. Thank you.
And Deb, that's in some sense a preview for the last session of the day. The last session of the day, we'll pick up the issue of, okay, what have we heard about the research that's going on? What's good and exciting about that? But then how do we move it forward? What are the next steps? What are the questions? What are the teams? What are the structures? And so appreciate your kind of giving us a kind of little foreshadowing about that. Biba, introduce yourself. Go ahead.
My name is Biba Tata. I'm a staff chaplain at Mayo Clinic, Rochester, Minnesota. I am also a Transforming Chaplaincy Research Fellow. So I realized recently as I was mentoring chaplain residents that the way we introduce ourselves as chaplain when we get into a room could either serve as a trigger or a barrier to a rich spiritual care encounter. So Marilyn, the video that you showed, the chaplain introduced himself as a chaplain who is coming to support the patient's spiritual and religious need. And I'm just wondering, if that patient was not so religious, would that conversation have gone differently, or what would have happened? So the way we introduce ourselves as we move forward with the taxonomy work, are you looking, one of the three components is the intervention. So I'm wondering if you're also looking at the ways we introduce ourselves as chaplains or establish a relationship with the patient. How would that help to even help us chaplains to do the work that we want to do, to satisfy the needs of the patients?
Thank you, Biba. So we have not looked at that. That is good observation, because I know that occurs when I'm in a trauma and the nurse says, so the chaplain here, you can see the fear on the person's face, right? So we do have established rapport and connectedness, demonstrate care and concern. And so maybe looking at how within those, what would be the link of the intervention could potentially be how we introduce ourselves. So as we move forward with the CTUG, another plug, then we can actually talk about those things. Thank you.
And isn't it a great area for research, actually? To what extent is the word chaplain a meaningful word for people? Who understands that word, who doesn't understand that word? What are alternative ways to introduce ourselves? We actually don't have good research about it, but we realize actually it's a pretty important area, and it's time to begin to work on it. Go ahead.
Hi, my name is Heather Kinsley, and I am actually an on-call chaplain at the North Shore University Health System, and I'm also a student at Garrett Evangelical Theological Seminary. My question really was for Sara, and I think I'm looking for your name, Patricia? Pat? I saw a real potential corollary between the SDAT model highlighting who it was that needed care and the stressors that you identified in the first presentation. And did that SDAT tool sort of corollary in any way, shape, or form with the top stress indicators that you found? And have you even had a chance to anybody look at that? So that's sort of my question.
So I haven't looked at that specifically, but I do know that some of the things in the SDAT are very similar to some of the themes of the distress items that we found. So themes of isolation, for example, themes of barriers to fulfilling your activities that fuel your identity, things of that nature. And I do think that a closer look at the links between the SDAT and the distress items that we identified would be helpful. So of course our purpose was looking for not only individual sources of distress, but ways that they might group together in order to target interventions. And our system does not routinely use the SDAT, but looking at that might be helpful to see whether or not that's something that can sort of illuminate where the interventions need to be targeted.
And so as I was looking at hers, I saw all the religious ones being on the low side, and so that correlated with my, I think correlates to that very strong connection to your religious base. And Georgia's right next to Alabama, so they're not quite as religious as Alabama, but they're close. I mean, they're in the Bible Belt still.
I lived in Texas for 12 years.
So you understand that Southern religiosity.
Yes.
So, but within that, it may be that is, because I wondered as I saw it, are we having trouble with that, but because of perhaps Pentecostal nature of our faith or whatever, that we are not willing to admit that we are struggling in that area?
Yeah, that's a really good point.
Yeah, that was one of the things that we had considered about that data, was whether people don't have the freedom to admit it, religious struggle, or whether because religiosity is such an important value in the South, whether people really do feel like they have support in that area. And anecdotally, I will say that a lot of people that I run across will, in the deeper conversations, talk about this real deep and abiding faith that they may not know the plan, but they trust that God has a plan. So it may be both and.
Thank you.